Hello, and welcome to InfoCardia, where our goal is to summarize major clinical trials in the field of cardiology in under 10 minutes. In today's video, we will begin a new topic. This series will cover heart failure with reduced ejection fraction. Heart failure is a complex clinical syndrome which is either caused by structural or functional impairment of ventricular filling and/or ejection of blood. As with many other pathologies, there's an increased incidence with age, and the three main underlying causes of heart failure are coronary artery disease, diabetes mellitus, and hypertension. Heart failure can roughly be categorized into systolic versus diastolic heart failure. While systolic heart failure results from decreased ventricular contractility, which causes ventricular enlargement and decreased ejection fraction, diastolic heart failure is a result of decreased ventricular compliance. It is important to note that systolic heart failure used to be termed heart failure with reduced ejection fraction. However, heart failure with reduced ejection fraction can present with both systolic and diastolic heart failure, and they are no longer colloquial terms. As you can see, there are many different ways to classify heart failure. The first of which is classifying heart failure by left ventricular ejection fraction. When left ventricular ejection fraction is greater than or equal to 50%, the condition is known as heart failure with preserved ejection fraction. Note that both left ventricular and diastolic volume and stroke volume are decreased, which ensures that left ventricular ejection fraction is preserved. When stroke volume and ejection fraction are both decreased, and ejection fraction is less than or equal to 40%, the condition is known as heart failure with reduced ejection fraction, otherwise known as HFrEF. Note that today's study will be focused on HFrEF. Finally, when left ventricular ejection fraction ranges from 41 to 49%, the condition is known as heart failure with mildly reduced ejection fraction. The second stage of classification includes the ACC/AHA, which stands for the American College of Cardiology or the American Heart Association. These stages include Stage A, at risk for heart failure, Stage B, pre-heart failure, Stage C, symptomatic heart failure, and lastly, Stage D, advanced heart failure. We hope to cover these stages in depth for future videos and encourage you to read up on them when you have time. Finally, I would like to talk about the NYHA functional classification, otherwise known as the New York Heart Association functional classification of heart failure. This system is used to assess limitations in physical activity and symptoms of patients with symptomatic heart failure. Note that symptomatic heart failure in the ACC/AHA staging system includes stages C and D. The NYHA functional classification is important because it helps us determine treatment eligibility and prognosis. NYHA includes classes 1, 2, 3, and 4, and I want you to take note that today's study includes patients classified under NYHA Class 4. In order to understand the setting of today's study, named Consensus, I want you all to take a time machine back to the 1980s, where heart failure treatment focused mostly on symptom control through use of diuretics and digoxin. ACE inhibitors had just come out, and Consensus sought to measure the effect of ACE inhibitors on heart failure. This was a multi-center, double-blind, parallel group study that included 253 randomized and controlled patients. 127 of these patients were treated with enalapril, while 126 were treated with placebo from the years 1985 to 1986. The average follow-up for these patients was 188 days with a range of 1 day to 20 months. This study included an intention to treat analysis with mortality as its primary outcome. The inclusion criteria were patients that were classified under NYHA Class 4 HFrEF. Recall that NYHA Class 4 meant that they had symptoms at rest. The patients also had to be undergoing optimal treatment, which was defined as at least being treated with diuretics and digitalis, although patients may also be on other non-ACE inhibitor medications. Other criteria included heart size on chest X-ray greater than 600 for men and greater than 550 for women. Exclusion criteria for the study included any patients with acute pulmonary edema, hemodynamically important aortic or mitral valve stenosis, MI within the previous 2 months, unstable angina, planned cardiac surgery, any right heart failure due to pulmonary edema, or serum creatinine measured at 3.3. The demographics included an average age of 71 years, with females making 30% of the cohort. Now let's go over the interventions for the study. Hospitalized patients were randomly assigned to receive enalapril or placebo. They were stratified by use of vasodilators. Patients received either enalapril or placebo at 5 mg twice daily for 1 week, then 10 mg twice daily if the patient did not become hypotensive. The dose could increase up to 20 mg twice daily according to clinical response. Patients were evaluated at weeks 1, 2, 3, 6, and 16, and then again at 6, 9, and 12 months, as well as the end of the study. Note that patients with worsening symptoms were recommended to start on vasodilators such as ISDN, hydralazine, and then prazosin. This study did include a protocol revision that occurred because of occasional symptomatic hypotension. This happened after 67 patients had been randomly assigned. Revisions included an initial dose of 2.5 mg daily with an increase to 2.5 mg twice daily if hypotension or creatinine elevation did not occur. This was applied to those at high risk, which was defined as sodium less than 130, creatinine 150 to 300, an increase in diuretics within the previous week, or treatment with potassium-sparing agents. Now let's go over the outcomes of the study. Comparisons for outcomes are measured at enalapril versus placebo. At 6 months, there is a measured mortality of 26% for those treated with enalapril versus 44% for those treated with placebo. Relative risk was 0.60 with a p-value of 0.002, and number needed to treat was 6. At 12 months, mortality was measured at 36% versus 52%. P-value was equal to 0.01%. Total mortality was measured at 39% versus 54% with a p-value of 0.03. It is to be noted, however, that the duration of the beneficial effect of reduction of mortality was not assessed due to the small amount of follow-up data. Also, enalapril benefits in NIHA classes 1 to 3 were not evaluated. Overall, this study was significant because it was the first one to explore the effects of ACE inhibitors in the treatment of HFrEF. This helped set the stage for upcoming studies such as SOLVED in 1991, which we will talk about next in this series. We hope that you learned something new today, and stay tuned for our next video. As always, don't forget to like, subscribe, and comment. Have a great day.